When talking about a differential diagnosis for someone who comes into my office who has a major depression, the clinician always needs to consider bipolar disorder. An individual who is bipolar and depressed, if they're in the depressed phase of the illness, they have depressive symptoms no different than someone who has what's called a unipolar major depression, where they're just depressions going to normal or just chronic depression. Now, we may not know who is at risk for bipolar disorder, but individuals who are bipolar go from depression and at some point have what we called manic or hypomanic episodes. Manic, full-blown manic episodes are described as things such as, and again, these symptoms can differ from one person to another and can even differ in the same individual over time, but manic symptoms can include things like a decreased need for sleep for an extended period of time and feeling rested, racing thoughts, feeling grandiose, an inflated sense of self-esteem, feeling raced and pressured, having pressured speech, pressured thoughts. People often get very impulsive. They make very impulsive decisions. They may get in trouble with the law, make poor decisions in terms of spending, sexual activity. Again, it's thinking, it's acting before thinking. Those are typical common symptoms of overt mania. Now, if that mania has resulted in someone actually getting into the hospital, or if there was ever a point where there were psychotic symptoms may mean that that inflated sense of grandiosity is so elevated, they actually believe that they have specific powers, the ability to do things that may not be real. That is what we call bipolar type 1. Those are people who have depressions but overt manic episodes. Hypomania is tricky. Hypomania and depression, when those two exist, that's called bipolar type 2. People who just have depressions and hypomania. Hypomania is very similar to mania, except you may have a less intense form of when someone gets high. Both mania and hypomania may have irritability, but very common in bipolar type 2s, you can see a lot of irritability. You may not feel good, but it may be irritable. A lot of people say, I just feel like I'm going to scratch somebody's eyes out. They just have very little patience. They're very irritable. They're always on the go. They may be very racy. They may be very creative. That sort of thing, when followed by a depression, or depression is somewhere interspersed there, I always think bipolar. Now, for the depressed person who comes into my office, I may go through a history. I may not know that they're bipolar, but if I put them on an antidepressant and they come back the next week and say, I feel wonderful, that's either a placebo response to the antidepressant or maybe bipolar. Because people who are bipolar, when they're depressed and go on an antidepressant, if they're not on a mood stabilizer, could potentially cycle into a manic or hypomanic episode. And very commonly that turns into what we call a mixed state, where it's very irritable, very poor frustration tolerance, again, not being able to sleep. People may feel dysphoric or have depressive symptoms mixed with feeling racy. They're always maybe potentially getting in fights, very argumentative. That may be the individual where I'm thinking, okay, we may have to stop the antidepressant, put a mood stabilizer on board, and if the individual gets depressed later, may consider an antidepressant later again. But sometimes we aren't able to make that diagnosis until it actually appears. But individuals need to be aware that if they have depressions that are not responding to treatment, or when they go on a treatment, they get it and lose it, or they get their response and then they become irritable, they should think bipolar.